my co-moderator, Dr. Ann Rosich, of an associate professor, Department of Epidemiology, Johns Hopkins Bloomberg School of Public Health, and myself, I wish to welcome you to the final of a 3-part global cervical cancer webinar series. The first part featured a session on overview of global initiatives in cervical cancer control. The second on latest scientific advances, tools and approaches to address cervical cancer control at country level. And the third, which is today, on ensuring effective implementation of cervical cancer prevention and control strategies. At the end of the series, you'll feel to put your questions in the Q&A segment of your toolbox, and there will also be credits available at the end of the session. You will receive an email to this effect if you are interested. I now have the singular honor and pleasure to call on Dr. Silvina Rossi of the Centro de Estudio de Estados Sociedad Buenos Aires to give a presentation on the role of implementation science to bridge the gap between research and practice in the implementation of HPV testing as primary screening in middle-income settings. Dr. Arosi.
Very much, Dr. Adewole. So, good morning or good afternoon or maybe good night. My presentation is about implementation science as an essential tool to achieve the cancer elimination goal. But first, I would like to state that I have no conflict of interest to declare. In May 2018, WHO made a call to countries to eliminate cervical cancer, a disease that is almost entirely preventable with existing knowledge and technology, if screening, treatment, and HPV vaccination are effectively implemented. But more than 70 years of cytology-based screening has shown that the path between screening and cervical cancer reduction is not straightforward, and that implementation of interventions doesn't necessarily result in expected outcomes. In fact, the evidence shows that the real-world application of new technologies can be highly deceiving in terms of resulting outcomes. The reason behind the failures is that technology is only one component of the broad health system, which is formed by blocks that function in interrelated manners. Besides, the health system is not an isolated planet, but it operates in dynamic interrelation with women and patients, whose health behavior will be influenced by a multiplicity of social, economic, and intermediate factors. And these two interrelated social and health systems being affected by the broad policy context. How these systems and their components are defined in each specific setting and its interconnections will modify the impact of an intervention on health outcomes. Implementation science is needed to understand which strategies will give us the greatest impact of an intervention in our own specific women's health system environment, and what components of the intervention will need improvement, adaptations, or modifications. To do that, it uses key intermediate outcomes that have been traditionally left out of efficacy and impact analysis, such as the reach, acceptability, fidelity, adoption, just to give an example of key dimensions that explain the success or failure of an intervention. And it does it by incorporating outcomes related to the variety of stakeholders involved in the process, providers, decision makers, women, funders, etc. The incorporation of this real-world dynamic into the planning, implementation, and evaluation of evidence-based intervention and the methods and frameworks we use in a specific scenario are the core of implementation science. So in this presentation, I will show you very briefly how we have used implementation science in Argentina, a middle-income country, for introduction of HPV self-collection. International evidence has shown that HPV self-collection is effective to detect disease, and is accepted by women from a variety of settings, with huge potential to reduce barriers to screening among hard-to-reach women. Nonetheless, translation of this acceptability into packages of care in Argentina raised several key questions. Would it be acceptable for women if community health workers offer it during home visits? Would it be effective to increase screening uptake? What the core components should be? What are the method's main limitations in the local context? HPV self-collection was introduced in Argentina through the EMA project, a mixed method study that included a pragmatic cluster randomized trial with 200 community health workers and formative research to evaluate promoters, providers, and women acceptability and perspectives. The study showed that the strategy was accepted by women, community health workers, and health provider, and it resulted in a fourfold difference in screening uptake between arms. An important result of the EMA project was the definition of the four main core components of the strategy. These were the training of community health workers, the steps to follow during the actual visit, including provision of information about cervical cancer prevention and HPV testing, and a 10-minute step-by-step explanation on how to perform it. The third component regarded sample handling and transportation to health centers, and the fourth one specified follow-up and treatment referrals. In 2014, HPV self-collection was extended to the whole province and became a routine programmatic strategy to increase coverage. Between 2015 and 2017, the strategy was introduced in 4 additional provinces. The scaling up process generated new questions. Do primarily health workers accept to incorporate it as routine practice outside the context of a randomized controlled trial? Is it effective to reach the target population? What are the main limitations when applied at scale? What is the level of fidelity in the implementation of the strategic core components? To respond to these questions, I will present results of 3 studies that use implementation science to improve the scaling up process: a mixed method evaluation of the scaling up, a fidelity study, and a mixed method study to evaluate effectiveness of an mHealth strategy to increase adherence to triage. Evaluation of the scaling up was carried out using the REEM framework, which is particularly appropriate to assess the public health impact of an intervention as a function of 5 factors that are considered necessary for success: the reach, effectiveness, adoption, implementation, and maintenance. The analysis showed that self-collection had an adequate reach, with 10% of these very hard-to-reach women screened with self-collection that year. It also showed that it was highly adopted by community health workers and resulted in a 40% increase in screening of the target population. There were few implementation problems in the screening phase, but obstacles for assuring triage and diagnosis, which resulted in a reduced detection rate when compared to what was achieved in the randomized controlled trial of the EMA project. So a main conclusion of the scaling up study was the need to develop new strategies to increase triage and diagnosis among positive women. The level of fidelity in the implementation of the scaling up of HPV self-collection was analyzed through a fidelity study carried out in the district of La Matanza, in the Buenos Aires metropolitan area, a setting completely different from Jujuy in the northern province, where self-collection was introduced and developed as an intervention model. La Matanza is an urban setting with 2 million inhabitants, 30% of which are poor and live in very difficult material circumstances. Insecurity is a main problem, and the primary healthcare system differs in many aspects to the Jujuy system. The most salient one here is that health promoters are not salary workers of the health system, but women from the community who receive some sort of economic support from the Social Development Ministry. The study main question was how far the implemented intervention actually adhered to the prescribed model established in the EMA project. It included observations of health promoters during the offering of cell collection and evaluation of training workshops. Results analyzed so far showed that there has been a high level of adherence, regarding the training and the sample handling and transportation core components. However, we did detect adaptations regarding the offer of cell collection, which are mainly the result of the different social urban contexts where women live and their relation with the health promoters. So we found that due to the fear of insecurity, it was very common that women won't let health promoters enter their houses, and the offer had to be carried out at the house's front doors. As a result, the contact was shorter with fewer pieces of information provided to women and less time for the whole offering. This did not impact the quality of the sample taken by women who did accept self-collection, but it might have an impact on the overall acceptability with less women accepting the offer. We also observed that once again, adherence to follow-up was challenging with reduced level of triage when compared to levels obtained in the EMA randomized control trial. So to finish, I would like to present the third example, in this case, a study specifically designed to improve the follow-up process by increasing women adherence to triage. And to do this, we designed and evaluated an mHealth-based intervention that integrated HPV self-collection, the work of community health workers, a screening information system, and text messages used to communicate with positive women and community health workers. The study design followed the structure of an effectiveness implementation hybrid type 1 trial and used a mixed method approach. It included formative research to devise content and framing of the messages, a pragmatic cluster randomized trial to test effectiveness of the intervention, and research about the acceptability and implementation of the strategy. The study showed that most women accepted messages. For them, they represent the close link with the community health workers. And at the same time, for these workers, the messages are a facilitator of their work and link with women. The intervention was effective at increasing triage adherence among HIV positive women, with a 19% improvement in the intervention group due to the mHealth strategy, suggesting that mHealth technologies can have a key role in communicating with women with reduced access to health services. Summarizing, the studies showed that when offered by community health workers, HIV cell collection is acceptable to women and providers and effective to increase uptake. When scaled up, adoption, acceptability, and effectiveness is maintained. However, there has been some adaptation of key core components, therefore further adjustment of the offer will be probably needed. Adherence to triage and follow-up can be challenging. However, mHealth methods are effective to communicate with women with reduced access to the health system. They increase follow-up and they are accepted by women and providers. In the end, the main lesson is that to make any screening method work, implementation science is a necessary road for assuring screening effectiveness in the real world. I would like to acknowledge all the institutions that took part of the presented studies or were funders of them. I would like to thank, and I'm delighted now to introduce my colleague, Gina Ogilvie, who will be in charge of the next presentation. Thank you very much.
Thank you very much, and Silvina, thank you for that great presentation. So this presentation follows very nicely on from what you've described. So in this presentation, I'm going to review with you the sort of implementation research that needs to go on as you start to build the evidence base for a program in community and in country. So the ASPIRE program of research has been focused on the elimination of cervical cancer since about 2005, and it's based on a partnership between UBC Makerere in Uganda and the Uganda Cancer Institute since 2006. And one of the key things, and I think you saw it in Silvina's work, which is really important, is that this is actually based on ongoing and integrated consultation with the Ministry of Health, with healthcare leaders, to ensure that not only is the research useful, but actually it helps to support and implement the national strategies. So what I'll describe today is our phased pragmatic research approach that we have led in partnership with UCI to help inform the Ministry of Health. And this is a picture of my co-PI, Dr. Carol Naksiga, and Dr. Jackson Arem, who's the head of the Uganda Cancer Institute. So when you're designing a research program with an implementation focus, there are a couple of critical elements to keep in mind. So first of all, you're wanting to always keep the end goal of national or regional scale up in mind. So you're trying to generate information that actually has that ultimate goal in mind. I specifically described when our partnership started, which was 2005, and we've had a formal MOU since 2006. So folks know that we've been working with our UCI and Makerere partners for over a decade. And so these authentic established partnerships are really critical to build trust and to ensure that you have a real pragmatism in your design. Your design needs to be responsive to input from partners and stakeholders, and particularly those partners and stakeholders also needs to include, sorry, I seem to have lost my slide there. See, it needs to include patients as well. You need to plan the trial as a program implementation. And I want to highlight this in particular for those of us who've spent a lot of time in clinical epidemiology and in randomized trial design. There's a tendency to have these sort of purist trials, which are very interesting and can, are designed with ensuring there's absolutely no confounders across the two arms, et cetera. But in reality, when you actually go to implement those, as you know, that's not what programs actually look like. So you have to have a trial that has a pragmatic lens and that has program implementation, so is embedded in the reality of what the health system looks like, and not simply a trial that is designed to look at compare one outcome, but has no sense of the type of health system it needs to be implemented in. And interestingly, we also recommend using the REAIM framework to ensure that you have process evaluation as part of the entire study design. So I'm going to show you some of the publications that we've gone through over the years in order to help inform the Ministry of Health in Uganda and the Uganda Cancer Institute about the utility, particularly for us, has been the focus as well, has been self-collection. And I just highlight some of these publications. Particularly, I want to start at the top where we actually engaged with patients. The first thing to do is actually to understand whether women were willing to collect their own self-collected specimens. And so this was a door-to-door community-based survey. We learned that there were some critical elements that we had to explore further, including the role of embarrassment. And so we led a quantitative study to better understand how did embarrassment impact on screening. And then also men's perceptions, because what we learned from both the women, but also the community leaders, that the role of their partners was critical, and partners needed to understand what we were doing in terms of self-collection. We then moved to community-based cervical cancer pilot to understand, and I think Savina did a really nice job, and I'll describe how you need to look at all of the measures along that screening cascade. We also had a specific focus on women living with HIV because, as folks know, that women with HIV shoulder a much larger burden of cervical cancer. And then we actually moved to a pragmatic clinical trial where we actually compared the uptake of self-collected HPV versus VIA in community. And right now, and then we moved on to then also do cost effectiveness analysis. And now we've moved from looking at self-collection in an urban setting, which is what the data I just showed you, now moving to conducting self-collection in a rural setting just outside of Kiseni, to get a sense of how we can scale up in those community settings, those rural community settings. And just again, one of the critical things is having data to help inform as you're moving with your program planning. So this is the result of our self-collection project in Kiseni, which is a neighborhood in Kampala. And what you could see was that women were much more likely to self-collect than they were to attend VIA. So now as we move from our urban setting to our rural setting, this is the type of data that we need to look at when you're starting the program design. So looking at the preferences, looking at the health provider preferences, but also look at the system preferences and look at women's preferences. I want to highlight a few things in this. And this was done with qualitative integrated studies to generate this critical important information. One of the key things was one of the facilitators for screening was that there was a high awareness of need. One of the other key things was when we'd done our work in, for instance, in Kiseni in Kampala, we used a private lab and used a certain type of HPV testing. The Ministry of Health was very clear with us that they wanted us to look specifically at the gene expert because they wanted it integrated into the HIV and TB testing that was already at the community labs. So again, this is the kind of thing, if you go ahead and just plan a trial without speaking to the Ministry of Health, without understanding what they want, you might use a different type of assay or you might use a different type of testing. And at the end of the day, they might say, well, we can't roll this up. We cannot use this in our programming. Other interests and priorities, they said, was around developing the skills of nursing staff and ensuring that nursing and nurse midwives were central to any program rollout. Some of the barriers, and I'll just highlight again some of them that we flagged, were for instance, no established specimen transport mechanism. So we had to make sure as part of our program that we had a structured specimen transport mechanism, but we also that we documented that, evaluated that, looked at the quality of that, so that we could then give that type of information to the Ministry of Health. I think the other critical thing when we're looking at cervical cancer screening is to keep in mind that it's not just about uptake. I know I showed you some uptake data, but what we really try to do is make sure that we define our sample size calculations based on early detection and on early treatment. So what's really critical is not just that women self-collect, but that they, and Silvina referred to this, but that they also engage in the treatment. So we actually do all of our power calculations based on those stage 2s and 3s. Of course, stage 1, you have to have uptake in order to screen, but if you don't have the engagement in early treatment, we really haven't sort of improved women's lives. So that's really important. We're not going to go over this in detail, but just again, Sabina mentioned a logic model. This is what our logic model looks like. And you have all the data and inputs, the activities, the outputs, and the outcomes that you're looking at to keep your evaluations really in focus and holding you to account. So what are we now doing in ASPIRE Mayuge? So as I said, Mayuge is the rural region we're going to be looking at. So we've designed a sequential, pragmatic, 2-arm cluster randomized trial. We randomize at the level of villages, and it's in Mayuge district, which is just east about just near the head of the Nile, east of Kampala. And the aim is to determine the most effective method of community-based cervical cancer screening for women in rural Uganda. And as mentioned, we also use the RE-AIM framework. And so just a very high level, this is who can participate. That's Dr. Carroll and Dr. Rawat doing some of our preliminary assessments with our partners in Mayuge. And here's our flow of our arm 1, and I'm going to show you at a high level, then I'm going to show you some more detail, and then I'm going to throw in the COVID description. So arm 1 is door-to-door recruitment, and again, this is generated from our community partners who said we want to understand the difference with door-to-door recruitment versus community mobilization. So you can see arm 1 where we went door-to-door with the village health team, offered health education, did self-collection in the home, sent this sample to our lab partner at the Healthcare 4, and then we did counseling and results at home with follow-up. And again, as mentioned, this follow-up is our main outcome. Our proposed arm 2 was a community mobilization health day where we did community health education, and then we would go to follow-up education, self-collection in a private tent, then follow-up and give results in a private tent. This is just, I'm just showing you this again for the level of detail that we get into, and we work through all of this with our community partners. So we're all clear about what we're doing. And you can see there's some critical things. For instance, we have the specimen transported by the hub rider. So then we measure that. So we have some quality metrics as well to understand how well does that work. This is, of course, this is all founded on our partnerships and existing resources, so it can be integrated right back into community. And then there's the reality of COVID. So we had completed RM1, and I'll just briefly show you some data, but of course COVID came along. So now we're working again with our community and health system partners to say, how do we resume research, but we are also respectful of the local situation and lockdown. So again, this is guided by the local ethics committee and guided by the local safety plan. So we work in partnership with them for them to tell us what is safe to do in their communities. And so we've had to readapt. So ARM2 now is going to be actually, as you can see, here's our team has worked very carefully. And so the ARM2 is going to involve smaller groups, pre-screening, careful registration for that community, the sort of group education, but the group education is going to be much smaller. So here's the status update. As I mentioned, we completed ARM1 recruitment, and we are assuming and planning to resume ARM2 in September. And some preliminary data, you can just see the average age of women, the education level, and the history of pregnancy. And we have very low experiences of cervical cancer screening. And just to get you guys, give you guys a sense, here's our preliminary HPV results for the ARM1. So what we can say is that recruitment in ARM1 exceeded our expectation. Community support is very high, and that screening, the finding is that this is feasible, and of course screening is critical to the Ugandan strategy. So I want to thank you for your time. I want to thank the whole global HPV team and my co-PI, Dr. Carol Nakasiga, Dr. Jackson Arem, the head of UCI, and then Dr. Beth Payne, who's been our real program lead in this, and the rest of our team, including Lori Smith and Adri Yu, and all our trainees who've been critical to the work. So now I want to hand over to the final speaker of the morning, Dr. Carla Alfaro, who will be talking about cervical cancer prevention in El Salvador. So thank you very much.
Good morning. Thank you, and thank you for the opportunity to present our experience implementing HPV testing into the National Cervical Cancer Screening Program in El Salvador, the CAPE program. I have no commercial relationship with any corporate entity that produces or sells products related to HPV testing. This is the outline I'm going to go. I'm going to follow through the presentation. Before CAPE, El Salvador had a cervical cancer screening program based on conventional cytology, but despite the efforts, the screening coverage rate was one of the lowest in Latin America. We did a small study that was performed in 2010, where we did a retrospective analysis to evaluate the adherence to recommended follow-up care after high-grade cytology. The results shown that only 44% received treatment within a year of the diagnosis, and the majority, the 51%, did not have treatment at all. The reasons were related to women not attending to their colposcopy appointment or not receiving the PAP result. These results were presented to the Ministry of Health authorities, and it was perfect timing because at the time, the World Health Organization recommended the inclusion of HPV testing to national screening program. Although the tests were too expensive to be procured by countries like El Salvador, we saw an opportunity that came up to apply to a donation program for a low-cost HPV test. So the Ministry of Health and BHI partnered to present a proposal for the implementation of this type of test. We had consultants from NCI, PAHO, national societies like colposcopy, OBGYN, pathology that were also involved in the process. And in 2011, we received the approval to implement this as part of a pilot project. This was launched in 2012, and this was a three-phase project to evaluate the feasibility of HPV test implementation and treatment algorithm. We compared colposcopy followed by biopsy and treatment according to the guidelines versus visual assessment triage followed by immediate cryotherapy treatment, because we wanted to assure the proper follow-up of all women with a positive test. So this project was implemented in one of the 5 regions of the country, the Paracentral region, where we screened 2,000 women in 4 different municipalities, and then we increased the number of women in the same setting to 8,000. And finally, we included all the region with the 63 municipalities and almost 20,000 women screened. This project ended in 2017. And during this project, we performed different studies, adherence to HPV screening, acceptability of cell sampling. We compared results from cell sampling versus provided collected sample, and we were also able to make a cost effectiveness study with the Harvard group, which was key to advocate for the implementation of the test. The results from this study were that screening with a low-cost HPV test provides greater health benefits and than the current pap smear. Routine screening with low-cost HPV tests every 5 years is cost-effective compared to pap testing every 2 years. Screening with low-cost HPV tests followed by visual assessment triage is more effective and less costly than low-cost HPV tests with colposcopy triage. So we presented these results to the health authorities and also to different societies, OBGYN, colposcopy, pathology, other organizations that were working on cervical cancer prevention. And because of the good results that were obtained, not just on the implementation of the test itself, but to the high follow-up and treatment rates that we had compared to the previous intervention, a consensus was made, and we included the HPV test and the treatment algorithm into the national guidelines. This is the one that we are currently using. There is a provider collection sample, and all HPV test all women that have HPV test positive results have a visual triage and are treated with cryotherapy in the same visit. And if they're not eligible, they are sent referred to colposcopy. So in order to be able to implement the test and assure the proper follow-up, other interventions had to be made. We had to modify the screening forms to include both PAP and HPV testing in one form. Really important is that an online surveillance system was built from zero. The Ministry of Health started working on it since the beginning of the pilot project. We definitely encountered some difficulties regarding the data input into the system. We went from basically no data found in phase 1 to having 50% in phase 2 and 100% in phase 3. There are important indicators measured that are key also for a better monitoring and supervision at all levels. We have number of women that are screened either with PAP or HPV, number of women that are positive, the one that had their visual assessment, that actually got treatment or were referred to colposcopy. Training and education of all personnel is key also for the success of the program. Different trainings were performed for nurses, doctors, health promoters in cervical cancer prevention, HPV testing, sample collection, and also on how to approach and educate women about the disease and the importance of the screening and adequate follow-up. Also trainings of nurses, doctors regarding triage and treatment with cryotherapy are performed to assure the quality of the treatment. So the national scale-up started in December 2018. Our expectation when we started this project back in 2012 were that we were supposed to end in 2015, the pilot project, then moved to the central region in 2016 to the Occidental region in 2017, Oriental region in 2018, and have a full national scale up by 2019. But the reality was that we had encountered some problems, and there was a delay on the implementation of the test for the pilot project that ended in 2017. We were able to implement the test in two regions, Occidental and Oriental region, in late 2018. And this year, we were supposed to start the screening in the Central and continue in the Paracentral region, and to be able to have a national scale up in 2021. This is the total number of personnel trained over the years, 4,754. We had screened around 94,000 women. And definitely we faced a lot of challenges over the years. First, there was a reluctance by local stakeholders to change cytology-based screening for HPV testing. We've seen that when we increase and expand our program, there is a loss of follow-up that also increased. There are long intervals between program steps, so there are always some problems that we've encountered and that have delayed our intervention. It's definitely important to conduct implementation research in our limited resource settings, because this is a way to advocate for a change based on our research findings. There is also an impact of COVID in our program. Right now, health services are focusing to combat the pandemic. We have also women that are pending for treatment in two regions of the country. And there is also a delay on the implementation on these new regions for this year. So we were supposed to screen 80,000 women by the end of 2020, but due to COVID, that it's definitely not possible. There is a new possible target, and this is to screen 40,000 women by the end of the year. The Ministry of Health is working on including self-sampling into the national guidelines, because we think that this is the only way that we can reach that target. Thank you. Now I'm gonna pass it over to Dr. Rosich.
Okay, I first want to start out by thanking our three speakers. As somebody who is involved in implementation science myself, I could ask you a million questions, but I am going to go to our Q&A panel because I think it's a really great opportunity to talk about three different but very large, right, ongoing efforts. And not surprisingly, the first question that I have that I'm going to throw out to all three of you is with regards to what HPV tests you are using. So if you guys are able just to comment on your experience with the HPV tests in each of your program, I think that would be helpful for the audience.
Sure, I can start. So because we've been now heading up to 15 years, there's been an evolution in that. So the first round we worked with CARE HPV. The second round we worked with Lipo, and as I mentioned, this time we're using GeneXpert. It's really, for me, as a partner with the UCI, MOH, and the team in Uganda, it's really what they feel their community is most likely to implement. So that's how we've guided it, and that's been the evolution for us.
Okay, great. Silvina?
Yes, in Argentina, HPV testing is purchased by the National Cancer Institute through a national tender. So the test that is used is the test that won that tender, and up to now it has been the hybrid capture-2 test.
So in El Salvador, so we started this as a donation program. We use CUGH, and the Ministry of Health really consider other tests, but the fact that they are too expensive, and countries like El Salvador cannot procure tests that are more than $10. So that's the reason why we used these tests.
Okay, great. The next sort of few questions that I have are going to be for you, Dr. Rossi. I'm going to group some of them together since we had a few that came in during your presentation. And the questions are around the use and the challenges about the community health workers. So the first is, you mentioned that there was a challenge allowing them in the house. And so the question was with regards to, did you from the very beginning select female-only health workers? And so did the gender of the health worker have any effect on this? And then the second part of that question is, what messages did you use to sort of prepare the community? So did you inform the community by radio, or what method, and what did you say? And did you face any objections from community influencers such as traditional healers or church leaders? So 3 parts, which I will repeat as needed. Oh, we're not able to hear you. Maybe you're on mute.
So when HPV self-collection was first introduced in CUGH in northern Argentina, we did it through the primary healthcare system, and their community health workers are part of the health system, and they routinely visit homes twice a year. So these are very well-known workers by the families. So we didn't find any problem to let them go into the houses. And that was certainly an advantage. When the HPV self-collection was scaled up into the greater Buenos Aires metropolitan area, which is a completely different setting, we saw that women had problems letting health workers go into their houses. So these are 2 different settings and 2 different situations. We didn't see any objection of traditional healers. It was well accepted by providers, the CSORs, and the communities. Women with no doubt prefer it to a clinical examination at the health center. And we didn't observe any problem with male community health workers offering self-collection. I think the key in that place was that they were very well-known workers by the community, whereas in the Buenos Aires greater metropolitan area, there were only women who offered a self-collection.
And then just one follow-up question for you, Dr. Arasi. Did you deliver messages to the community to get the word about the trial out? And so what method did you use, and what were the messages in either of the settings or across settings?
There were some communication through the media, TV and radio channels, but I think that the impact of these campaigns were quite limited. We did an evaluation of the effect of these campaigns, and we observed that the main communication channel was the visit of the community health worker. This is someone they trust, and they are used to this visit. And I mean, for them, it was enough that the community health worker knocked at their door and explained and did the offering. I think that the impact of the mass campaign was very limited.
Okay, great, thank you. To Dr. Alfaro, the question is about the surveillance system that you were part of creating. The question is whether this is a paper-based or digital-based paper system, surveillance system.
Yeah, it's digital-based. It's an online system, yes. So, yeah.
And then the second question is with regards to scale up, and you sort of showed the transition on your scale up plan. So within each of the regions, as you've moved to them, what is the penetration or the actual uptake of screening within the different communities?
Actually, so since we're doing this in basically rural areas, so basically like the population is basically the same. So we have not encountered any difficulties regarding acceptability of these tests all over the country. We might expect to have different something different in the metropolitan area that we will hope to start next year. But yes, we don't have we haven't found any obstacles regarding acceptability of the test or any other problem.
Okay. And what is the screening rate or sort of the proportion of women eligible for HPV tests that have been screened in the different regions?
So what we were planning to do is to have at least 20% of women between ages 30 to 59 each year to reach 80%, 70 to 80% in 5 years. That's the plan that the Ministry of Health have right now.
Okay. And then another question, and this is, I think, for all three of the programs. And I'm just curious, sort of, when we think about scaling up and then moving into a maintenance phase, right? What is the sort of cost sharing? So a lot of this is happening in a research context where the research study might be providing some of the financial support, particularly for the human resources involved. So how did that vary across your studies, and how are you thinking about when the research period ends and those funds are no longer there and moving into the maintenance phase of these, given that you have achieved a lot of scale up within your research context?
In Argentina, all the studies were done in the context of the regular health systems, and human resources are the resources that are normally part of the health system. So at that point, there was no change from the research scenario to the programmatic scenario. I think that was one of the keys for success.
Okay. Dr. Ogilvie?
Yeah, I think that for scale up in Uganda, this is part of why we've spent so much time ensuring that the Ministry of Health and UCI are the ones who select and recommend the testing approach and the strategy, because it's got to be integrated. So ultimately the costing is going to land with the Ugandan Ministry of Health and their partners. So that's why the design has been, it wouldn't be helpful to design a trial or implement a trial that wouldn't be that you couldn't scale in community. So for our team, that's how we've selected our approach, and so it ensures it's aligned with the feasibility for the Ugandan Cancer Institute and MOH.
Mm-hmm.
In the case of El Salvador, so this started as a donation program for the pilot project. Basically, like the Ministry of Health have received the test as a donation, and also we help with some of the supplies that were required for treatment of women. But for the national scale up, actually the Ministry of Health procured 80,000 tests for Occidental and Oriental region, and about the same amount of tests for the central and paracentral region that is going to start this year. So, and he is in charge also of all the costs for the treatment of women. They use the same personnel that they currently have. They hired a couple of data assistants for data entry into the system, because we've seen that was something that was needed. But yes, basically the Ministry of Health took over the whole program, and they purchased the tests and everything. Yeah.
Okay, good. Thanks for providing that information. And this is a great, since this is an implementation science focused seminar, I think it's a nice follow-up question is, can each of the speakers comment on how they distinguished implementation practice from implementation research, and not just within your projects, but also with your stakeholders, since it can sometimes be a fine line to thread?
Okay, that's a very good point. Sometimes I think it's difficult to distinguish the two. And many people ask, well, but what exactly is implementation science? But I think that it's mainly working with decision makers to incorporate the research structure into the implementation strategy, and making people to understand how important it is to collect the data and analyze it, and doing this analysis all the time during the implementation process. So you are all the time checking the problems and making corrections and adaptations. So you don't just make one implementation, but the implementation is being changed and modified all the time. I think it's incorporating this view of the research that it makes the difference.
Yeah, I would just echo, I think, what Selena said. That was a great answer. And I think I gave the example, when you look at sort of that logic model and the sort of detailed flow, that part of what you want for implementation research is really to ensure you've got abilities and you're mindful of evaluating elements. I use the hub riders as one example. How efficient were they? How did they pick up everything? Did everything get dropped off? Were the samples all usable? And so it's that mindful evaluation accompanying every sort of part of the implementation that I think is the key for implementation research.
Yeah, I agree with Dr. Rossi and Olivia regarding this. So it's really important that around the intervention we make different research studies to be able to show the results, the data, and how we can troubleshoot some of the problems that they might encounter all over all the steps in the implementation process.
Great. So another question that I have, this is going to go to Dr. Alfaro. And it's a question about how, in your context, do you address the loss to follow-up? So you're using an HPV triage to visual triage for immediate cryotherapy. So first, a question with regards to the acceptability of that, and then also loss to follow-up, particularly as we need to for women who are not eligible for cryotherapy.
Yeah, so women really, this is they do really accept this kind of intervention, because this is something that allows them to have treatment faster than to usually go to colposcopy, do several appointments in order to get treatment. And that's where women were we were losing women before CAPE, because they have to go through all these visits, and sometimes they don't, for economical reasons, they don't have access to go to the hospital. So it reduces from 5 visits to 1, basically, because it's when they come for their results, we do the visual assessment triage, and we do the treatment in the same visit. In the case of women that are not eligible for cryotherapy, so they are referred to colposcopy, but we managed to have a connection between the health unit where we are performing the visual triage and the colposcopy clinic. So we make an appointment via telephone. So the women, when they leave the health unit, they already have an appointment, and we're cutting steps on them to go and do the appointment at the hospital and other that might affect the attendance of these women to the colposcopy clinic in case of the ones that are referred. Yeah.
Mm-hmm. Okay. And then just to sort of put that in juxtaposition to the research context, for example, of you, Dr. Rossi, right, who is having a different algorithm. And so the same question is sort of what are ultimately with your mHealth, right, which has started to address some of the loss to diagnosis, what are the treatment rates looking at, and what are some of the barriers around completing the continuum of care?
So what we observed is that once the woman is diagnosed with disease, the treatment rates are very high. In many places, there is a navigator systems that provide support to the women once it has been diagnosed with a lesion. So at that point, the treatment rates are very high, around 85%. The problem is mainly with triage because you have around 30% of positivity, and it's not feasible to establish a navigator system for this percentage of women. So I think in the end, mHealth technologies can make a difference. And also we know that other triage methods and other tests and other algorithms are being developed, and we can foresee a future with artificial intelligence as it has been developed. So I think that in the end, we will have a new generation of tests and triage tests that combined with mHealth technologies and social support to women, we will make a real difference in it.
And then a question to all three of the research, or all three of the countries that you guys are working on. This participant has noticed that this community health workers seem to be a critical component. And so the question is do the three countries that you're representing today have robust national programs to support community health workers, with the reflection that that is not true in all settings? Can each of you comment? Dr. Ogilvie, do you want to start?
Sure. I think for Uganda, they certainly are aspiring to every region having a robust framework for that. What I would say is they certainly every CH4, CH3 has a sort of network of community health workers. The way they're paid right now varies, and it varies dependent on what activities are going on. So I think my partners, as well as UCI and MOH, would love to see that even built up even more, and to a more robust program. But certainly those tentacles are already established in Uganda.
Yeah. Dr. Rossi?
Well, I think it's a very good observation. Primary healthcare system is the key to reach women, and primary health workers are a very important resource to do it. And I think that there should be a strengthening of this system. Argentina is a federal country, with each province has its own Ministry of Health. So the organization and distribution of these workers is not even in all provinces. And we can see the difference from Jujuy to La Matanza, and how this affects the offer of self-collection. So that is something that has to be, that we need to focus, and we need to bring the attention of the need to strengthen the primary healthcare system for the cervical cancer elimination, no doubt about it.
In the case of El Salvador, so we do have health promoters that are basically persons that are living at the communities that they serve. There is one health promoter per between 200 and 500 families. And they were really important for this specific type of implementation, because they are the first contact that the women have at the community. They visit women at the community to talk about cervical cancer and the HPV testing and the importance to having a screening, and to follow up with the results and the treatment in case that they are positive. So yes, we don't have, the only area that we don't have health promoters everywhere is the metropolitan area, and we will probably face some challenges next year when we try to implement this in this region. So we need to try to figure out what will be the best way to do.
Okay, great. I see that we're coming up on our time. There are a handful of other questions that we did not get to. We apologize for that, but we certainly want to thank all of the attendees today for their participation and their interest in the speakers. And I'm going to hand it over to Dr. Isaac Adewole to close out our session.
Thank you, Anne, for the able manner in which you moderated the session. I think we have come to the end of this three-part webinar series on global efforts to reduce cervical cancer. What will it take? We've been on this for the last 3 weeks, and we looked at several issues in this matter. We considered the overview of global initiatives in cervical cancer control. And last week, we looked at latest scientific advances, including tools and approaches to address cervical cancer control at country level. Today, we had an interesting presentation from 3 countries, from Uganda, from El Salvador, and from Argentina. And we believe that when we key into this, particularly with the release of the 90-70-90 WHO agenda, I think we can really set ourselves on the path to eliminating cervical cancer. It is anticipated that if we vaccinate 90% of our guests by age 15, we offer effective screening to 70% of the population, twice at age 25 and also at 35, at age 35 and 45, and then ensuring that 90% of those with lesions are treated, we will achieve a 10% reduction by 2030, and will be on the path to achieving elimination. It is my sincere expectation that we will all, at individual and at country level, put something in action. What is now left for me is to sincerely appreciate Anne, who is my co-moderator, and to thank the consortium of universities for global health, as well as NCI, for putting this webinar series together. We thank you all. Bye.
Thank you.